Okay, the final speaker before we have our panel this morning is Dr. Bruce Carleton. So Bruce is going to be talking about a program that, again, has been going on with Genome BC now for quite some time, the implementation of a pharmacogenetic ADR Prevention Program in BC. And he'll be telling us about the work in cisplatin and anthracycline. And delighted to have you, Bruce. Thank you.
Okay, here we go. So I'm glad you're delighted to have me. We'll see if you feel that way after. You can ask questions. I'm going to try to be done in 20 minutes, which is a bit of a hard call for me. But just so you can ask questions. So this is a project that Mike Lane and I are doing, and we've been working together for quite a few years now. And this is one specific aspect of our pharmacogenomics program together. And this is about implementation and about genetic testing to improve patient health outcomes. And what I'm going to describe to you is the project and where we're heading, the objectives. I mean, this is an observational trial. This is not a randomized trial, and it's not a randomized trial by design. We specifically chose a methodology that was not randomized, and hopefully you'll understand why in a moment. This is not, I think that a lot of genetic testing papers still think about genetic testing as dichotomous outcomes. You know, you either test and it's useful or it isn't. I don't think we're at that point yet, certainly not related to where we are with these particular drugs. So I want to first talk about adverse drug reactions because that's the basis of what this is all about, and then the progress so far that we've undertaken and the progress to date in terms of identifying genetic variants that are predictive of a given adverse drug reaction or ADR. And then finally, and really the bulk of the talk should be focused on plans for clinical implementation. But you need to understand ADRs, you need to understand what we've done to date to understand the implementation. So quickly we'll go over those things. I'm not going to read my slides, so you read them while I talk, or don't read them and just listen to me. I'm more interesting anyway in my slides, I hope. And basically this is a huge problem. Probably the fifth leading cause of death in North America is prescription drug side effects. Fifth leading cause of death. If you don't believe me, you can believe U.S. Pharma that reanalyzed the data that that was based on. It was published in 1998 in the Journal of the American Medical Association. They have some legitimate criticisms about that number, and they reanalyzed the data and suggest that it's the eighth leading cause of death in North America, prescription drug side effects. So I hope you all feel better. I don't, and it's a big problem, and it's really a public health problem that we need to address. So it's great that we have effective agents for disease. It's not so great that they cause side effects. Actually, I'd like those two words eliminated from the English lexicon. They are, in fact, adverse drug reactions. Big problem. Most reactions aren't actually captured. About 95% are never reported to regulators, so most literature estimates are actually underestimates of the true problem. So first thing we did was we established a Canada-wide ADR surveillance network. Since 95% of adverse reactions aren't reported, where is the problem, what needs to be addressed, wasn't really defined. And so we were able to convince Genome Canada at the time and other partners to help us build this, and we did. And the network started originally in Vancouver, where our center is at the Children's Hospital. It's now expanded across the country. It includes oncology treatment centers and 9 adult centers as well. Princess Margaret is one of our most active adult participants in this process, and Jeff Liu is collaborating with us there, as well as a number of people from the BC Cancer Agency. We've recruited quite a number of serious ADR cases and drug match controls. The numbers change all the time. As of September, which is the latest numbers that I have, I still don't have the December numbers yet, we're looking at closing in finally on the magic 50,000 mark in terms of the number of ADR patients and drug-matched controls that we can draw from and do this particular work. I want to talk to you about two specific reactions and two populations of patients. The first is cisplatin-induced hearing loss, deafness, of course, being the absence of hearing and the worst possible outcome that can occur. Very effective agent, there's no question about that. 80% in round numbers, 80% remission or cure as a result of using this. It's used in a lot of different cancers, including ovarian and lung. In kids, we use it rarely because most kids have lymphoblastic leukemia, non-solid tumors, but it is used in children as well. About 1 million patients a year in North America and Europe receive the drug. It is widely used, obviously, but it does actually have a problem related to severe bilateral hearing loss. Probably upwards of 30% of adults experience this, not really known since they don't routinely, adult oncologists do not routinely test hearing at baseline and then through therapy. In pediatrics we do, so we do know the absolute number of children who actually develop hearing loss. It's about 60% at our center, and this would be at the level of needing either hearing aid placement or cochlear implants, mostly just hearing aid placements. We did a study with the economics group at UBC and looked specifically at the lifetime cost of hearing loss. It's about $500,000 per patient that develops hearing loss to the point of needing hearing aid replacement. So this is an expensive problem. It's also a concerning problem. Obviously, we're trying to keep patients alive, so the loss of hearing may be an acceptable outcome, but it depends. So we'll talk a little bit about that as well. So our prediction model, published in Nature Genetics in 2009, shows that as you have more risk alleles, you have an earlier onset of hearing loss, more frequent hearing loss, and more severe hearing loss. And so this was very promising to help us begin to work with the regulator, FDA, actually, on a change in the drug label, recognizing the genetic basis of this very problematic effect. And in fact, the label change was made 2 weeks ago by FDA. It's now online and public, and recognizing the work that we did. And so one study of 162 patients, extremely well characterized, was enough to get FDA to act on this. And we're still working with them to work further on the label and look at predictive testing. We're at a bit of a catch-22 in the pharmacogenetics world, which is that regulators want to be able to say, get a test. They don't regulate the practice of medicine, so they might recommend versus mandate a test more readily. But the challenge is who's going to do the testing. So I get lots of emails and phone calls every week from clinicians who want testing done for their patients. The FDA worries if we make a recommendation, are a bunch of clinicians going to say, well, where the hell do I get this test? And which labs do it, and which labs are accredited, and all of these kinds of issues. So this is all developing, but we've had great relationships with FDA and working very, very closely with them on these issues. So what can we do based upon this genetic marker? Again, survival is obviously more important than hearing, but they should not be looked at as independent outcomes. They are, in fact, on the same continuum. In fact, oncologists at our hospital use hearing loss to guide when to taper the dose and discontinue the dose of cisplatin. Hearing loss is the endpoint. Survival is the goal, but you can't really use survival as an endpoint for treatment. Otherwise, people would be on the drug for the rest of their lives, and they would suffer the adverse consequences of that. So you have to stop the drug at some point. Hearing loss is used as the stopping point in children's oncology group protocols. And it's quite specifically oriented towards that internationally. So there are alternative medications for some cancer types that are thought to be less low toxic. This kind of test could help us decide when an alternative should be considered. Perhaps modifying cisplatin dose, again, has to be tested in a prospective trial to show that modifying the dose doesn't affect survival, but does improve or lessen the impact of an ADR, perhaps less hearing loss or avoid it altogether. Because we live in a province which is very large, we have a lot of patients that come from very remote locations. We can increase monitoring of patients that are high risk, making sure that they get audiometric testing so we know that decision point of when to stop therapy or when to lower dose, which is currently what's done now. And of course, there are protective strategies that we're working with the US-based COG group to evaluate as well. Sodium thiosulfate sulfate trial we're doing right now, expecting about 1,000 patients to enroll, and we'll look at the pharmacogenomics of sodium sulfate responders and non-responders in this population. So conservatively, we feel that implementing testing would save $16 million a year in Canada. That's also in the same study published in Pharmacogenomics Journal. It is a conservative estimate. I think it's a reasonable estimate. It depends upon if we can actually get a handle on finding the best alternatives and what to do in these patients. So this is something that we're trying to do, which is to sort of move away from the paradigm that you dose until there is permanent irreversible hearing loss and then stop. Okay? That's primitive in my opinion. We should be stopping before that point. The challenge is if you stop too early, you might have earlier death. And survivability is affected. So these are the trials that these genetic tests have helped us to begin to understand need to be done to move to the next level. So quickly, anthracycline-induced heart failure, which is another part of our pharmacogenetics testing program. Again, heart failure being the worst outcome, cardiotoxicity occurring in a great number of patients. About 1 million patients in North America receive this drug every year. Very effective as adjuvant for breast cancer, as well as very commonly used in childhood cancer because we have such, most childhood cancer is lymphoblastic leukemia. Very high survival rates, excellent drug with a problematic side effect. 16% of patients suffer some degree of cardiomyopathy. That's probably an underestimate of the true risk. Not all patients are tested, for instance, adults, like we do in pediatrics. I can tell you that 3% of our patients and pediatric patients worldwide actually develop heart failure while on treatment. 3%, very high number. And there's a high mortality rate associated with severe cases. And so again, looking specifically at profiling patients based upon genetics and clinical information, not just genetics, we can actually profile patients into 3 risk groups. Low risk, meaning they have almost no risk of cardiotoxicity, almost half of the population, which is particularly helpful, and a high risk group. And this high risk group is actually very high risk. 36% of those patients develop serious cardiotoxicity, defined as a shortening fraction less than 26%. In the first year of treatment, 24% of those patients actually go into heart failure and need cardiac transplant. And so this is a big group of patients that we're looking at. And we want to be looking at these patients differently, not as if they're all the same. The low-risk group is particularly interesting to me because it may, in fact, be a group that we should be using higher doses in if they are diagnosed at late stage, so say stage 4 lymphoblastic leukemia. Should they, in fact, be getting more aggressive chemotherapy? No one knows. That also has to be prospectively evaluated, and that's something that we're now asking about in the pediatric oncology world as a result of this. So what are the potential clinical options then for personalized anthracycline therapy at the moment? Well, I had Dan Bernstein, the head of pediatric cardiology at Stanford, come up and take a look at the data, spend some time with us. And one of the things that we decided as a group was that for low-risk patients, but they should continue to receive the same echocardiographic monitoring. For an intermediate-risk patient in the middle, probably intensified follow-up, and high-risk patients, we might be thinking about, again, cardioprotectants, adding a drug to protect the heart during chemotherapy, alternative medications, possibly lower doses. All of this has to be tested. And then also earlier treatment with drugs used to prevent damage to the heart, and that's something that we can do now, and cardiologists in fact do, which is kind of interesting and fun to work with because there's more information now about who these patients are before they get chemotherapy and as they're moving through the system. Instead of waiting for toxicity to find next steps, we can actually now predict in whom these toxicities are going to occur and follow them very carefully. This is another way of looking at it. More than 75% of children in the high-risk group develop cardiotoxicity, compared to only 4% in the low-risk group, showing that there is value in these genetic markers. This work was all published, including our receiver operator characteristic curves in the Journal of Clinical Oncology about November of last year.